Today we will discuss the management of class 3 malocclusion. It is considered the least common type of malocclusion in comparison to the class 2 and 1. It contributes to 5% of all the cases, and it is observed among the Japanese and Koreans more. It is defined as the occlusion of the mesiobuccal cusp of the permanent maxillary first molar between the mandibular first and second permanent molar, instead of occluding with the mesiobuccal development groove of the permanent first molar. It is observed with what is called an incisor overlap, where the mandibular incisors are overlapping the maxillary incisors. So the main objective of treating this malocclusion is to regain the normal overlap of the maxillary tooth over the mandibular tooth with the appropriate overjet and overbite. We know the classification of the malocclusion type 3 is that it is an dentoalveolar, or it is skeletal, or it is a pseudo class 3 malocclusion, where we have an occlusion prematurities that must be removed to maintain the normal development of the mandibular arch. We can see that the profile is concave and we have a prominent chin. You can see the canine having a class 3 relationship instead of normal occlusion of the anterior of the maxillary canine in the space between the mandibular canine and the first premolar. It is occluding between the first and second premolar due to the protrusion of the mandibular arch. We can see that there is an increase in the lower facial height. The treatment of the class 3 malocclusion depends on the phase, the time, and the type. If it is not skeletal, we are dealing now with the dental class 3 malocclusion. In the pre-adolescent and the adolescent, there is no need to surgery. We only need it when there is a complete classification of the maxilla and sutures, the developmental sutures. We can use removable orthodontic appliances like the expansion appliance, where we expand the maxillary here, the maxillary arch, to get the overlap of the maxilla over the mandible. We can use also some myofunctional orthodontic appliances like the Frankel 3 or the reverse activator, also the class 3 bionator. Some fixed orthodontic appliances can be used, where we use an intramaxillary elastics, and here we rely on the dental camouflage, where we do some tiltation of the maxillary incisors to the labial side, and the mandibular incisors to the lingual side. Some orthopedic appliances that restrict the growth of the mandible is the chin cup and the anterior face mask with RME, and the anterior face mask. Also, we can use the headgear if it is having a high pull. This is the Frankel 3 appliance, and this is the face mask with the rapid RME. This is the fixed orthodontic appliance. We can see the intermaxillary elastics that is going to protrude the maxillary anteriors and retrude the mandibular anteriors. We have seen that the correction of the Z class 3 malocclusion is the eliminating the prematurities. It must be done in the pre-adolescent and adolescent phase before the complete classification to prevent the formation of class 3 skeletal real malocclusion. And we have said before that to differentiate between the ZEDO and the real class 3 malocclusion is the ability of the patient to get their mandible to the centric relationship. Treatment of the anterior cross bite is by using lower anterior inclined planes or removable orthopedic appliance incorporating expansion screw designed for anterior expansion. The posterior crossbite is treated by rapid maxillary expansion. When we have a severe skeletal class 3 malocclusion, we tend to go for the surgical approach, where if we have both a mandibular prognathism and a maxillary retrognathism, we use the Lefort 1 osteotomy correction approach. That's it.